So Patricia Miller will be joining us. She's the founder and an executive director of SoCal Speech Therapy and Swallowing Diagnostics. And she's going to discuss the importance of speech therapy in the management of Parkinson's disease. She's going to talk about how the Speak Out program can benefit patients at different stages of their PD journey and what to do if you are concerned about your voice. SoCal Speech Therapy and Swallowing Diagnostics is an insurance-based, adult-focused speech therapy practice with a specialty in treating PD patients via telemedicine statewide in California. They are currently credentialed with Medicare, HealthNet, Healthcare LA IPA, Lakeside Medical Group, and Regal Medical Group. And with that, I am going to go ahead and turn it over to you, Patricia. If you can you go ahead and start sharing your screen? And
Yes.
I'm going to adjust my view here, so it's just showing you because it'll make it a little bit easier. And we are good to go. Thank you so much.
Thank you. Thank you, Jessica, so much, actually, for everything you do and organizing us all this morning. It's really people like you who are getting us together and helping us get the word out about important things, like the topic I'm talking about today, which are changes in speech and swallowing. So on our agenda, let me see if I can move this a little bit. It's taking up some of my screen. So I am going to talk about changes in speech and swallowing and the implications that those changes have, and being aware how to advocate for yourself, how to get referrals for therapy. So we all know about the medication that the neurologists recommend, and I've obviously highlighted some of these dopamine agonists, the carbidopas, the levodopas. These things are not news to someone who has Parkinson's. These are the medication management of symptoms. And the therapeutic management is typically physical therapy, occupational therapy. And obviously, I'm pretty passionate as a speech therapist about raising the awareness about how important speech therapy is. I don't know if anyone listening online or at the gym is seeing a speech therapist, but sometimes people are surprised to know that you are wonderful, fantastic. Sometimes people are surprised that we have to do a lot with swallowing. So if you start experiencing difficulty swallowing, you are going to see a speech therapist. So I always introduce myself as a speech and swallowing therapist. Now, a lot of the neurologists that I work with, when they have the motor disorder specialty, they're pretty amazing where they really want someone to even explore complementary medicine. They're not just managing medication. And the complementary medicine can be any of these things mentioned here, whether it's art therapy, music therapy, boxing, yoga, all these things combined have been noted to be very beneficial. Okay, but I'm here to talk about what I call the 3Ds, okay? The 3Ds are dysphagia, which is the medical term for trouble swallowing, dysphonia, which is impairment in the voice. When the voice changes, the quality of the voice changes, it can become hoarse, breathy, the pitch can change. That's what dysphonia means. And the last D, which is dysarthria, and that occurs when the movements aren't as big of the lips and the jaw, and the speech can sound slurred. So these are pretty big topics. It's really what I dedicate my life's work to. I'm going to talk about it in 30 minutes. So if you think about, gosh, we really went over that quickly. We're just kind of skimming the top of these things on today's talk. And obviously at the end, we can open it up to questions, and you have my information at the end as well if you'd like to email me. So dysphagia, which is the trouble swallowing. We break up the swallow into 3 stages: the oral, the pharyngeal, which is your throat, and the esophageal. We're going to focus a little bit more on the oral and the throat level, but a lot of people I work with say they have reflux. That's an esophageal stage of the swallow. And if you have trouble with one stage of this swallow function, another stage can be affected. Okay. So if you're having trouble controlling things orally, it can kind of spill back into the throat, and that can affect the pharyngeal stage, the second stage, which is the throat. So for normal, and here I am going to have to kind of minimize my screen a little, not my screen, but the view. The normal stage of swallowing, what happens is the lips close, they form a seal, the chewing and mastication of food begins, the food is mixed with saliva, that little cohesive unit, we speak of that with the term bolus. We form a bolus, we transfer it to the back of our mouth. And that's the normal oral stage, okay? So to know what's disordered, we need to know what's normal. Now, some changes that happen in the oral phase with Parkinson's is there begins to be poor lingual control, decreased range of motion of the tongue, which can lead to also difficulty chewing foods. And like I said before, the oral stage can affect the next stage, which is your throat stage or your pharyngeal stage. And about 78% of people will notice an increase in saliva. They'll say, I have more saliva, or I'm drooling, or I have an increase in the production. And it's not actually that there's an increase in the production so much as the reflexive swallowing that occurs is not happening as frequently. So I tend to tell people I work with, you can pop like a sugar-free piece of hard candy in your mouth. You can start putting like a piece of gum in your mouth to have that sensory input to swallow. A little more of an invasive extreme case is when a neurologist could inject it's kind of like a Botox called Xeomin to kind of dry up the mouth, but we don't really want to go to that level when possibly it could be mitigated by chewing some gum or having some hard candy in your mouth. This is a cross-sectional of someone's mouth and their throat, and changes that are seen at that pharyngeal or throat level can be a feeling like food is stuck in the throat or that residue is in the throat. And that's due to a decrease in these muscles kind of coming and squeezing together. Now, the thing that we're all really always wanting to avoid is aspiration. And aspiration basically means that material, food or liquid, is getting into the airway, going down the wrong way, okay? And typically, if this happens to any of us, our body really tries to protect us, and we start coughing until we kind of move that out of the airway. Silent aspiration is when somebody's eating and drinking and they look just fine, but they start exhibiting symptoms of something not being fine, like they're spiking a temperature and they're feeling some discomfort in their chest when they're inhaling. And then a chest x-ray might show that there's something going on in their lungs because things are going down the wrong way. Now, silent aspiration cannot be viewed. Obviously, it's silent. It can only be seen on an x-ray. So speech therapy has two tools that we use in the medical setting. Modified barium swallow study is an x-ray of your swallow where you would go in if you're not in the hospital. You go in as an outpatient, and the speech therapist has you drink some material that's called barium. They also mix it in with a little bit of food, and they see what's going on with your mouth and how's the food going down your throat, okay? The second test we have, it's a little more invasive. It's called a fiber optic endoscopic evaluation of swallowing, or a FEES. And that's where we take a thin little a camera at the end of this fiber optic cable. We put it in your nose and we kind of hover above your throat, and we see how you're doing while you're eating. Are you protecting the airway? So I'm going to show you a video of the first one, the x-ray, the modified barium swallow. Hopefully everyone can kind of follow along with my cursor here. This is the spine. What you see, this black material, is the barium that the speech therapist has given this person in the X-ray suite. Now, we want food to go to our throat, our airway closes, and down the esophagus to the stomach. We don't want any food or drink to go into this trachea. I'm going to play it twice just because it happens so quickly so you can see that this person, am I having trouble playing that? Let's see if I can do that. Okay, if we can't play that, that's okay. This person gets this material into the airway. Let me see if we can do it on escape mode. Let me see if I can. Here we go. I'm going to play it like this so you can see it. Here we go. And now you see the material goes right into this person's airway. And this is what I'm referring to. This black line right here is technically aspiration. Okay, this is the trachea. And I can tell that this person's not coughing. So we're going to play it for you one more time. The person is asked to drink. When you see the mouth fill with the black material, that's by their mouth, their tongue, and it's going to go back into their throat, and then you're going to see it spill over into the airway. So we'll play that one more time for you. And here it kind of fills up and goes into their airway. Okay, so let's go back into play mode. So that's really the worst of the worst. Not intended to scare you, just intended to be educational. So you know, the whole thing is keeping myself safe when I'm eating as safely as possible. What's the worst that can happen? The worst that can happen is what you just saw, which is material going into your airway. If that starts happening chronically, a human body would get sick. It doesn't want coffee and eggs, orange juice. A body would start having issues if that was happening a lot. So what are some signs? Some signs of dysphagia are coughing, throat clearing with meals, drinking and eating, possibly choking on saliva, or a feeling that food is stuck in the throat. Sometimes when people say, oh, I feel like my food is stuck right here, and they kind of point to their sternum area, and they have more trouble with solid food, that gives me a big red flag that it's possibly esophageal, that it's a little bit lower down and they're having a hard time emptying. And that's typically when they have a solid food dysphagia and they feel a sensation that's a bit referred and they feel something is stuck and they kind of point to the top of their chest area. If there's a weight loss or dehydration by not being able to eat enough, or, which is pretty much the most serious one of all, a recurring pneumonia. Okay. All right. These are very general precautions, and I understand that they're basic, but they are important. To sit fully upright at 90 degrees. Try to sit at a table when you're eating, if you're able to. Reducing distractions. If you're lucky enough to live with family, a lot of us talk when we're eating meals. And that's something that if you're starting to experience some difficulty, try to minimize your distractions and focus on what you're doing. And also think about the timing of meals and medication. When you're on, off, how do you feel? Okay, so like I said at the beginning, we're moving right along. We're going to talk about speech and changes with Parkinson's, changes in speech. Okay, these are the three subsystems. Over here you have the lungs, respiration. At the top here, phonation. I don't know if any of you have seen this before. If you've been scoped, if you've had that second study that I mentioned, you've possibly seen this before, but those are your vocal cords. And your vocal cords are those two little white strips that look like a V. They come together and close to produce your voice, and they also protect your trachea, your airways below that. And lastly, over here at the bottom, we have articulation, which your lips, your tongue, those are the parts of anatomy that are going to make you sound more articulate and make those crisp sounds. Approximately 90% of people with Parkinson's will develop dysarthria. during the course of the disease. And voice abnormalities tend to be the first indication of dysarthria, followed by articulation and fluency abnormalities. I thought that was a very interesting thing to include so that you can check in with yourself or your loved one. How do they sound? What's their voice sounding like? Let's talk a little bit about the dysarthria. This is, I think, our second D out of our 3 Ds. Dysarthria, there's a decrease in breath support and in the breath speech coordination. Sometimes people sound very monotone or monopitch, and everything sounds the same, and there's no prosody or melody in the voice. Okay. There can be difficulty initiating the voice, and the imprecise sounds resulting in that slurred sounding speech. The lips, the tongue, the jaw, they're not making these bigger movements as they were. So things are going to obviously sound different. The rate can be very fast or it can be slow. And the most common dysarthria in Parkinson's is something that we call hypokinetic dysarthria. Dysphonia has to do with the quality of the voice. So the volume tends to be reduced. The voice can become hoarse or breathy, and the voice can become shaky or tremulous. I've also had quite a few patients whose voice sounds like a glottal fry, and glottal fry kind of sounds like this, where the voice sounds like that. So the quality of the voice can change. This was published in the Journal of Clinical Neuroscience in 2020. Emerging evidence suggests that voice is the earliest sign of motor impairment, and it's because the complexity and fine motor control and vocalization may result in dysfunction here before the limbs. So I've had a couple of people I work with say, I was diagnosed in 2017, but I knew things were going on with me about 3 years before my official diagnosis. And when I really look back, I know that there were some changes in my voice. So voice is usually the thing that starts changing, even though it's subtle. Sometimes it's subtle. The self quiz is something I'd like to ask you all. This is what we do when we're completing an evaluation. It's part of the VH110 index. I didn't include all 10 questions, but these are important questions to ask yourself. My voice makes it difficult for people to hear me. And then you would rate that 0, never, up to 4, always, with 1, 2, 3 in between. Sometimes, almost always. People have difficulty hearing me in a noisy room. My voice restricts my personal and social life. I feel left out of conversations because of my voice. I feel as though I have to strain to produce voice. And lastly, people have asked, what's wrong with your voice? Sometimes I have worked with people who say, I don't think there's anything wrong, but my spouse wants me to come in here. And that's very common with Parkinson's because the basal ganglia, everything that's kind of your monitor to tell you how you're doing in terms of your function, your motor function, is a bit impaired. So that's why sometimes family members are the ones that notice these changes first. Speech and communication. I'm obviously very biased. I'm a speech therapist. I think this is very important for all of our quality of lives. We need speech and communication to maintain our employment. We need it to maintain our social contacts. So much of our identity is wrapped up in how we communicate and how we sound. The roles that we take in our family, accessing healthcare, communicating with your doctor, your team. It's very important to be able to communicate. And when speech disorders and Parkinson's start showing up, this can lead to a decrease in participation. It can lead to social isolation. It can lead to less positive social exchanges and less communication with friends and family. And we obviously want to try to prevent that as much as possible, because there are programs out there like the one that we offer that are fantastic. So really time is of the essence. And when you get a diagnosis like Parkinson's, try to get in to get an eval. A lot of people that I work with a big, a big range, but folks who are really still kind of participating and their voice is very audible. At the beginning, it was kind of like, why do I even need this? And then it's about understanding that we need to maintain your strength. Okay. So we're going to turn the corner with some really positive news, which is a protocol that's out there that is wonderful. That's called Speak Out. So Speak Out therapy was created by the Parkinson Voice Project, which is based in Richardson, Texas. And the Parkinson's Voice Project is the one that developed this program. Samantha Elanderi, who is a speech language pathologist, is the founder of the Parkinson Voice Project. And the treatment involves education, individual speech therapy, and then ongoing therapy after you're done with the individual speech therapy, which can be done online. This whole program is based on the principles of the late Dr. Daniel Boone. And he was a speech language pathologist who worked with patients with Parkinson's. And he told a story about working with a group of people who had Parkinson's and asking them to complete an automatic task. And he asked the group to count from 1 to 10. And the group began to count. It was very soft, not incredibly intelligible. 1, 2, 3, 4, 5. And that's how it sounded. And then he asked the group to count backwards. And when they counted backwards, the intelligibility went way up. And people started saying 10, 9, 8. And so that was the big aha moment in Dr. Daniel Boone's research, that intention is really the crux of this program. And the premise is that a conscious effort to change how one speaks or moves can make automatic tasks more effortful. And it actually activates a different pathway in the central nervous system. So when you're lacking dopamine, the firing neurons at the automatic level aren't working properly. So we're trying to take the process of speaking and move it from automatic, which is in the extrapyramidal system, to the intentional, which is in the pyramidal system. And using this system makes speech intentional instead of automatic, and it improves voice and clarity. And that's the neuroscience behind this. And you're always going to hear intent, intent, intent when you're doing Speak Out. Okay, I am going to have to get out of this screen to show you some before and after. This is the fun part where you can hear some patients before they did Speak Out and after they did Speak Out.
Sorry. The noise is much stronger, much clearer. The words are more concise. I sound like a human being.
Count from 1 to 15.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. My wife has noticed it was my parents. It's me talking, and it's me. Only as part of this process did I learn that I had relinquished control of my voice and relinquished a significant part of my life, which is being sociable. and social, and now I think I'm back in charge, and I'm on my way to being back in charge.
It's much softer and more difficult to speak. I speak louder, clear, and with intent.
Okay. She actually had the benefit, this is the last video, of actually being a singer in a choir, but she still started feeling the effects on her voice. Here we go. This is Ellen.
Tell me your full name.
Ellen Petty Gilbert.
And when were you diagnosed with Parkinson's disease?
This past summer, May or June, I can't remember which exactly. It's kind of in between, yes.
Have you noticed a change in your voice or speech?
Yes, I have. I sing in the Allen Symphony Chorus, and I'm very concerned about the changes in my voice.
What have you noticed?
Well, there's more hoarseness. I don't have the breath control that I used to have. Singing, I guess that's probably the two things that bother me the most.
Have other people said anything to you about your voice or speech?
No, not really. Well, my husband says that sometimes he has trouble hearing me. I chalk that up to his inability to hear, but I'm not sure that that's true. I don't know. I may be speaking more softly than I used to.
Tell me your full name.
Ellen Joyce Petty Gilbert.
And when were you diagnosed with Parkinson's?
In June of last year, 2018.
Now that you've completed the Speak Out therapy program, do you notice a change in your voice or speech?
Oh, yes, I definitely do, in my voice particularly.
What have you noticed?
Well, I'm speaking more loudly, and people have noticed that and told me they've noticed it. And my singing voice also has improved, and that was one of the reasons I wanted to do this, so that I could continue to sing in a choral group.
Good. Have family or friends noticed a change in your voice?
Yeah, my husband says he has. I don't know that my daughter or my grandchildren have.
Well, what has he said?
Oh, he just says that he notices that I'm speaking more clearly.
Okay.
And that maybe he's not getting as deaf as he thought he was.
Okay. Okay, so I wanted to include this because I loved it so much. Jennifer Cody, who was part of the Parkinson Voice Project, a speech therapist, was giving a presentation, and she talked about an oral care analogy that really hit home with me, and I'd like to share it with you. She talked about how we all take care of our teeth, and we brush and hopefully floss daily. We go in for cleanings and checkups, and we repair cavities. We try to get these fluoride treatments to prevent major issues. And then taking care of your voice should be viewed this way. But sometimes people will say, oh, well, my voice is fine. I'll go seek someone out when I notice a problem. And she talked about how, like, we wouldn't do that with our teeth. We wouldn't wait until we had pain and then had to go get a root canal. So viewing your voice the way we view oral care is really the way we should look at it, something to be taken care of daily. And so this is something that I tell everyone I work with, and it kind of clicks. I have to take care of my voice. When I have this diagnosis, this is something that I have to commit to, like brushing my teeth, taking care of my voice. So the takeaways: don't wait until your voice is severely impaired. Early treatment is really the best treatment. It's easier as a clinician to maintain a voice than to restore it. And you do have to advocate for yourself. And I think it's because when we see someone who might have some gait instability and there's some balance issues, let's say they possibly fall down, they hit their face, there's a bruise, of course, you're going to get a referral to physical therapy. But if your voice gets a little bit softer, it's not exactly like something as horrendous as like you fell down and hit your face. But as we talked about during our time together, communication and your voice is a huge part of being a human being and participating in your life. So you do have to advocate for yourself. Any doctor can give you a referral to speech therapy. Hopefully you have a neurologist you have a good relationship with who has a motor disorder specialty. But I have people come to me and they've been referred to me by their ENTs. So as long as you have an order for speech therapy, you can be seen. We're also here for you. And this is our information, my information, the practice's phone number for you to jot down. And I have a couple things. Let me just open my screen up here. There we go. I have a couple things to share with you. So when you come for an evaluation, a speech therapist like myself evaluates how you're doing, get a speech sample, ask you to do a couple things to see if you are stimulable, if your speech, if your intonation, if your articulation changes when we cue you to do things a certain way. And at the end of the session, we actually call the Parkinson Voice Project while you're on the phone together. And we say, hey, I just finished working with Jessica. She's a great candidate for Speak Out. And the Parkinson Voice Project sends these workbooks to everyone. And these are the workbooks that we work out of. They don't charge anyone. They do now have a, if you'd like to pay it forward program, but their motto, which is wonderful, is everyone should have access to speech therapy who has Parkinson's. And that's really their philosophy. So they don't charge for these workbooks. And if you have a speech therapist who's certified in Speak Out, they can go ahead and get started with you. So one exercise that I wanted to share with you all, I'm not a big proponent as a clinician of giving people random exercises. And that's because each person is different. And if you go in for one of the x-rays that I talked about, that's really important to kind of inform your treatment plan. So that's going to tell a clinician, gosh, there's a lot of residue in the vallecula. They possibly have base of tongue weakness. It's like a physical therapist getting your x-ray if you have broken your tibia or your femur. It's a really nice blueprint for your therapist to say, these are the things that we should work on because this is where the weakness is. Now, one exercise that I have no hesitancy recommending is the effortful swallow. And that's because that exercise is something that just really targets a lot of areas that just strengthens the overall swallow. But the effortful swallow is pretty simple. And as it says, it's swallowing in an effortful manner and it's swallowing hard. Now, sometimes people cue people and say, pretend like you're swallowing a golf ball, which I don't really love because no one does that. But I like the cue like you're swallowing a grape whole or you're swallowing a piece of peanut butter and jelly and you don't have something to wash it down. So most of us are going to take a big gulp. When that happens, the tongue kind of goes up to the palate. You feel that seal and you feel like almost like a constriction of your throat muscles. Okay. So that is a really good swallow exercise to incorporate if you're experiencing some weakness or some residue in your throat. You can do those. And so you're going to have to tell yourself, I'm swallowing hard. Okay. And you should feel that tongue go up and create that seal against your palate. And then feel kind of like a contraction in the throat muscles. Can everyone try that with me? If your mouth is dry, it's going to be hard to do. If you have enough saliva to gather up, you can do that and swallow hard. Okay? And that's the effortful swallow. When we get into things that are a little more complicated, like take a breath, swallow, cough, I would never recommend that to anyone unless we've had an instrumental assessment that says that that's necessary. And if you're working with someone and they're asking you to do all kinds of things like put your chin down, turn to the left, turn to the right, hopefully you've done one of these studies, whether it's an x-ray or the fiber optic endoscopic study to do that, to implement those strategies, okay? The other thing I wanted to share with you is something that I always recommend to people I work with because it's easy, I love it, and it's so beneficial. I don't work with this company, but I love this thing. So I feel like I should work with this. So this little guy is called the breather, and it looks like a little pipe. And you can get this on Amazon. And this is based on something called respiratory muscle strength training. So if anyone on Zoom has been in the hospital, usually hospitals will give you kind of like a little cheapo version of an incentive spirometer. An incentive spirometer typically has 3 little balls, and you inhale and you see those little balls go up. Okay. And that's because you're kind of in bed, you're not aerating your lungs. So this little guy, the reason I like it is because you exercise upon inhalation and upon exhalation, and there's 5 levels. So you can start at a real comfortable level, and as you get stronger, you can kind of crank it up so you have more resistance. Why do I like this as a clinician? Obviously, there's benefits. There's respiratory benefits to this, but this also helps with the cough function. So when someone has a very weak cough, I immediately get them on a respiratory muscle strength trainer. And this has also been shown to help the muscles of the swallow. Okay. So I did want to share those with you as well. You don't have to get that brand, but a respiratory muscle strength trainer is something that's great to incorporate. I'm open for questions if anyone has any questions. The Parkinson Voice Project for Speak Out recommends daily exercises. They're only about 15 minutes a day. When I see someone, Stephen, I evaluate them, and then I usually see them twice a week. You don't have to do exercises online when you've worked with your speech therapist that day. But when you don't see your speech therapist, the beauty about that program is you just go on their website, and one little section says daily exercises. And she's been posting daily exercises for probably over 2 years. She has like 700 daily exercises up there. And they're intended to be something that you can do. It's not like an hour of your time. So you can go on there and do them for 15 minutes and off you go. I can't, as I clear my throat, I can't speak to why she didn't want you to do that. I think there's all different kinds of things in scenarios. If someone's habitually doing that, they can obviously be slamming their vocal cords together and create irritation. That's the only reason I can think that she wouldn't want you to be doing that habitually. If you were actually expectorating secretions, which is I want someone to be able to, if they have something in their throat, have enough strength to expectorate secretions. If you have like a tickle in your throat, that's kind of a different story. If you have post-nasal drip, that every time you try to inhale or start speaking, you start coughing, then that's another story that you need to kind of get that taken care of. So there's different reasons why people are going to kind of clear their throat. When it becomes like a constant, then I think that maybe the speech therapist was trying to direct you in a different area where you wouldn't be doing that as much, because you can cause irritation because you're slamming your vocal cords together. Also, we're big proponents of trying to stay on regular diets, thin liquids, as long as humanly possible. We're not a practice because the people that work here have a lot of clinical experience, and we've seen kind of really, really, really tough cases. We don't want to start altering people's diets unless it is the last resort, because thickening your liquid is not really always the answer. And if anyone tells you to thicken your liquid without one of those tests, you should get kind of like a little red flag up in your head. Thickened liquid is one of those things that was created because as a tool to prevent people from aspirating, and it's now ended up being quite a difficult thing because no one really wants to have thickened liquid when they're thirsty. So you have some people who just stop drinking and get dehydrated, which can cause other problems like UTIs. But also, if you don't have that instrumental assessment, that X-ray or that fiber optic endoscopic evaluation, someone's just guessing. Okay? So if you're coughing with thin liquid and a therapist says, just thicken it, you're not coughing, we don't really know what happened. Okay? So be cautious of altering your diet without an assessment, one of those assessments that I mentioned. Okay? Because you might not have to do that. Okay? You might just say, okay, well, this is a little bit weak. You should do some targeted exercises. You can incorporate respiratory muscle strength trainer. You should all be very conscientious of your oral care because oral health is very connected to your pulmonary health. So I'm talking about brushing your teeth 3 times a day, really keeping your mouth nice and clean. Your teeth, your gums, does your tongue look nice and pink? You can chew. I mean, well, the chewing gum's not really going to like clean it all out, if you can like probably, rinse and spit after your meals, trying to get obviously anything that's like visible in your teeth out. And as much as you can, if you can, twice a day because of work, but really trying to stay on top of it. If you can get those little like picks to get anything out from between your teeth. I'm a big fan of like brushing the tongue. Absolutely. So just, you have to think about it like the connection is huge between your oral health and your pulmonary health. So when you start having dental issues or your tongue has like a white film on it, or you have decaying teeth, bad breath, food between your teeth, that's a different picture when you have maybe a little bit of something going down the wrong way, when that's what your mouth looks like versus your mouth is very clean. Maybe a little water went down the wrong way. Your body can tolerate that. It didn't really inhale any bacteria. You're staying on top of your oral care. You're doing some respiratory muscle strength training. So you're trying to stay ahead of issues. You're trying to take care of yourself, make yourself as strong as possible. Good question. I'm certified in both of those. So I enjoy working with people and doing Speak Out just because I love the organization so much. I love that you don't have to sign up for anything. I love that they send you a workbook for free. I love that you can see me, for example, for speech therapy for 3 months, and then you can go for the rest of your life from the comfort of your own home and log on and to do exercises. So I love the accessibility of it. It's also intended to be about 30 to 40 minute sessions that are very functional. There's 6 steps. There's 4 foundational exercises that are done every time you work together, which are warm-ups. And then there's always going to be a reading component. And then they end each therapy session with a cognitive component. So instead of just reading something or doing an exercise for your breath support or your vocal flexibility, they're going to ask you to generate some answers. So, for example, give me the names of 5 cities, and you have to say that. You have to say that with intent. So it's pretty comprehensive. They curated the exercises with a lot of thought behind them. So there's, exercises that focus on your breath support, exercises that focus on vocal flexibility, because a lot of people get monotone and monopitch, articulation and rate. And then lastly, they always end with a cognitive component. So that's a little different than LSVT. And that's my personal opinion about enjoying that program. And also in LSVT, they ask you to kind of hold a note very, very long. And some people have experienced like some difficulty doing that. And Parkinson Speak Out, you just have to do sustained phonation for about 10 seconds. So there's not as much strain on the voice. So basically, all you have to do is just obtain a speech therapy order. And when you have a speech therapy order, that can get faxed to us. And then once, all we need is an order, a practice like ours. I'll just speak for our practice. We just need an order. And then we reach out to you to schedule the evaluation. When it's telehealth, you just click on a link and you see your therapist kind of the way we are now. And we go through kind of the whole evaluation. What's going on? When did you notice any changes? We ask you to do some reading. We kind of see what your, loudness is, how intelligible you are, meaning how clear are you to the listener. And then the therapist writes a report for the ordering provider, and that is sent out to that office within 2 days. And then that doctor signs it. And when they sign that, that means they agree to the plan of care. And typically the plan of care, we usually say 12 sessions. That gives us wiggle room. Some people are like, I feel great. Like, I feel really good after 8. And some people have wanted to stay with us for like 24 sessions because they like the check-in. They kind of like the accountability of like doing the exercise with someone. And so that's how it works. You obtain an order, you say, I have Parkinson's, I actually only see a PT, but I heard it might be a good idea to get an evaluation. You get an order for a speech evaluation and it gets sent to our office. And then that starts the process of sending you a link for your evaluation. That if you would like to specifically work with us, you could have the doctor fax it to our practice specifically, and we'll have Jessica has our information. And I've had, I've actually physically gone to talks and someone has walked up to me with like a little, it looks like a prescription for speech therapy, as long as I have that physician's information, right? So I can know who am I going to email my report to? We have to have a doctor order that, and we have to have a doctor sign off on that, right? Especially, obviously, Medicare. So it's so everything is done appropriately through the right channels. So the easiest way would be, I need a speech eval, and that order gets faxed to our fax. And then once it's faxed to our office, then everything kind of is in the system, and then you're contacted to see when you're available for your evaluation. Once you get your evaluation done and we request a workbook for you from Parkinson Voice Project, the founder does a webinar once a month, and she highly recommends that people, it's only like 45 minutes or an hour, but she highly recommends that people who are about to start this program watch it. So the only unfortunate part is it's once a month. So sometimes I'm like, oh my gosh, it's 2 days from now. Let's just get you in. Sometimes you have to wait 2 weeks. But it's very informative. I mean, I've been working for a while, and every time I work with someone, they say, gosh, I thought like I knew everything there was to know about Parkinson's. And she was very informative. And, it's a passion project. You can feel it with Samantha Elanderi out of Texas. So that is a little more specific, but that is something that we also try to honor, how they'd like people to start the program with the webinar under their belt, and then they already have their book delivered, and then they get going with their therapist. Good question, Jessica. Thank you. I think, and to answer Jessica's question, like I said, I have referrals from ENTs, anyone who has the ability to order. So even like a nurse practitioner in a neurologist's office. There used to be confusion. I had some neurologists reach out, and they actually thought that they had to choose between referring someone to PT or referring someone to speech because it was out of the same bucket years ago for Medicare. But if you have Parkinson's and it's indicated for you to have speech therapy, we just write something called a KX modifier, and you don't have to worry if you get PT. So sometimes people would call and say, I need this, but I'm also getting PT. Is it going to take? And so then there's that whole issue. But we're trying to kind of get the word out and get the proper information out that you don't have to worry about that if you're, if you have Medicare. And any type of doctor can refer you to that. So that's why I highlight the ENT, because my patient got a referral from an ENT because she had the study done where he looked at her vocal cords with the little fiber optic endoscopic evaluation. And she has Parkinson's, and that's who referred her to speech therapy. So it wasn't her neurologist. And it could be a general practitioner, like I said, a nurse practitioner, an ENT. It doesn't have to be a motor disorder specialist. Hopefully you have a good relationship with your neurologist out there, but it doesn't have to be that person. And part of the reason that, I appreciate you, Jessica, is because we're kind of the therapy. It's like PT, OT, and then speech therapy, but it's very important, as we all talked about. All of us care about communicating with others and eating and trying to maintain that as long as possible. So it's also a very important thing to keep going and keep strong. The actual program recommends that you check in every 6 months for a refresher. So It's not like, and that's the big thing. It's not like, hey, do this and you're fine for 5 years. It's like, do this and then you do exercises, right? Do that and you do exercises. You should check in. I like to say tune up for a tune up. But the actual program, so I have your workbook right here. You recognize this, right, Stephen? Yeah. Okay. So on page 3, remember, schedule a speak out refresher with your speech pathologist every 6 months. So that's something that's important, even after you go through the program, that you remember, hey, this works, but I do have to do it. And if you're committed to it, it's amazing, because you do hear changes. You do hear changes in people's voices and subsequently in like someone's quality of life, because they're not struggling to communicate with their loved ones and people in their lives. But you do have to commit to it. But
yeah, because I've noticed my volume's gone down from, above 80 decibels down to, it just keeps going down slower and slower.
Yeah, well, you should call me up, Stephen. We'll jump back on it. Yeah, but that's something that if you're not doing your daily exercises, but this is something that they put out there in their protocol to check in. So like I graduated someone 2 weeks ago and I told her, we're going to connect in 6 months so we can check in. And she said, great. And she was very committed. And I know she's going to do the daily exercises, but I'm still going to check in with her.
Good info. Thank you.
You're welcome.
All right. Unless there are other questions, we will go ahead and end the meeting. Thank you again all for joining us. And thank you so much, Patricia, for that wonderful presentation and all the information.
Thank you for having me. And thank you so much for the work you do, Jessica. It's really important.
Thank you.
Bye, everyone.
All right, guys. Yeah, have a great rest of your Saturday.